Hello, everyone. Good morning, good afternoon, good evening. So I think we have now over 132 participants joining. So we should start. So thanks again and welcome everyone to joining our webinar. Thank you for joining us for today's webinar. My name is Hala Jassim. I will start with the introduction and work with the panel on the facilitation of this webinar. This is one of the series of the webinars facilitated by URC under TB Care 2 project. And as you all know, TB Care 2 has been involved in infection prevention and control activities since 2010. Today's webinar will focus on infection prevention and control, respiratory protection for TB and other airborne infectious disease, including COVID-19. Just before we start, a little housekeeping before we get started. If you have any questions during the webinar, please type them into the question box in your Zoom control panel. We'll bring them up during the presentation and we'll also have time for a question at the end of the webinar. We have a very accomplished panel to walk us through major issues around IPC and respiratory protection for TB, as well as other airborne infectious diseases. And the panel include Paul Jensen, who will start with the presentation, followed by some questions to be answered and elaborated by the panel. Paul Jensen has been with CDC for over 30 years and has been involved with TB infection prevention and control and lab biosafety internationally. He collaborated with many ministries of health, NGOs, World Health Organization in implementation, training, and evaluation of IPC and lab biosafety measure. We will be also joined by Dr. Nardell. He's a professor in the Department of Medicine of Global Health and Social Medicine at Harvard Medical School, and an associate professor in the Department of Immunology and Infectious Diseases and Environmental Health at Harvard School of Public Health. He's an associate in medicine in the Department of Medicine and Brigham and Women's Hospital, PWH, in both Division of Public Health Equity and the Pulmonary Division. His research interests involve the control of TB under resource-limited conditions with a focus on the pathogenesis of drug-resistant TB, its airborne transmission and transmission control in institutions. He has recently tested interventions to prevent transmission of MDR-TB in a unique experimental facility in South Africa, in which large number of sentinel pigs served to sample the air from a 6-bed MDR-TB ward, part of MDR-TB referral center. We will be also joined by Dr. Grigory Volchenkov from NTB Transmission Institute. He is the vice chair of ETTI. He is a specialist in TB control and TB infection and control. He serves as head doctor at Vladimir TB Control Center since 2002. He implemented intensive TB infection control program in Vladimir region, Russia, supported by CDC, USA, and WHO, resulted in substantial reduction of occupational TB among healthcare workers. Since 2008, Vladimir Oblast TB dispensary became Center of Excellence for TB infection control. We will be also joined by Dr. Kerry Toder, who has worked in global health for over 20 years in various global health projects throughout Asia and Africa. Her research interests focus on occupational risk factors for TB among healthcare workers and preventing TB in healthcare workers. She has published several articles on infection prevention and control and occupational TB in healthcare workers. She currently serves as the TB project director for International Council of Nurses working to build the capacity of nurses related to TB, MDR-TB, and patient-centered care in China, Russia Federation, and 7 sub-Saharan African countries. We have on the panel also Sadim Ahmedov. I'm not sure if he joined, so hopefully he will join. He is a senior technical advisor at USAID, and he oversees TB and TB HIV programs in a large number of countries. So now, without further ado, we will turn the time over to our first panelist, Dr. Paul Jensen. Dr. Paul, it's to you. Thank you.
Thank you very much, Hala, as well as URC for coordinating with the NTB Transmission Initiative, and I'll give everybody credit at the end as well. Oh, sorry, there's just a delay here. So anyway, yes, I'm going to talk about respiratory protection for TB and other airborne infectious diseases. I'm going to start with a little bit of basics of airborne infection prevention and control. I'll talk about the hierarchy of airborne infection prevention and control. We'll talk about the introduction of personal protective equipment, or PPE, and we'll focus most of our time on 2 topics. One will be surgical and procedure masks, and the second will be N95 FFP2 respirators. Now, I know a lot of people are interested in environmental controls such as ventilation and UV. If there's time at the end, we could answer a few of those questions. I know there's already one on the board, but they're not the focus of today. And Hala will probably talk about the next webinar, which will include the ultraviolet germicidal irradiation, or germicidal UV. And then there'll probably be another one on ventilation. So we haven't forgotten the other topics, but today's topic is respiratory protection. There's a series of references, and in the handout, I also give you the link to those references. A lot of the material that I'm going to be talking about comes from the 2019 update to the WHO guidelines on tuberculosis infection prevention and control. Obviously, I can't skip over the 2005 CDC guidelines for preventing transmission in healthcare settings. WHO also has an extensive amount of information on COVID-19, as well as CDC. So when we're talking about these various topics, there's a lot of material online. And here's a nice picture from 1942. It's high-speed photography of somebody sneezing. And what do you see here? You see lots and lots and lots of large droplets. What do you not see here? You do not see the very small droplets, and we'll define that in a moment. But you do not see the very small droplets that may desiccate over time and become very, very tiny and remain airborne for a long period of time. So when we're talking about airborne infection prevention and control, we're talking mainly about those small particles that can stay airborne for a long period of time and that you can inhale. So let's talk about 3 different definitions. The first will be large droplets, which we generally define as larger than 100 micrometers. Some people call it microns, 100 microns. But the settling velocity, the velocity at which a particle like that would fall to the ground in still air, is greater than 0.5 meter per second, or 100 feet per minute. So they do fall out of the air quickly. When we talk about medium-sized particles that could be from 10 to 100 micrometers or microns, the settling velocity is a little bit slower. And when we talk about very small particles that could be 1 to 10 micrometers in diameter, they fall very slowly and could take days to years to settle out of a quiet atmosphere. And what does quiet atmosphere mean? It means a room that's perfectly still. And if you have some turbulence or air mixing in a room, it's possible, unless they hit a surface, that they never settle out. And when we talk about small particles, you may hear two terms. You may hear the term droplet nucleus, or you might hear the term microdroplet. Droplet nucleus and microdroplet have various definitions. Some will say 1 to 5 microns. Some will say 1 to 10 microns. Some will say 1 to 3 micrometers. But again, it doesn't really matter exactly what the definition is, but we do know from the physics standpoint that in a perfectly still room, a 1 micrometer particle will settle very slowly. Or to put it in simple terms, it'll settle 3 meters in 24 hours in a perfectly still room. You get a little bit of air mixing or air currents, it can stay airborne for a long, long period of time. Now, whether we're talking about tuberculosis, coronavirus, or something else, once that particle is expelled, it'll be covered in sputum, mucus, some kind of a liquid, and the water portion will flash off or evaporate relatively quickly. So what you're going to end up with is an organism or virus that's coated in something. So when we talk about viruses being much less than 1 micrometer, that's true for a naked virus, but in reality, it's covered in something, so it will be a little bit larger in size. When we talk about tuberculosis, I know there are a lot of people here that know about tuberculosis, but I just wanted to show one slide from the 2019 Global TB report from WHO. But 1.5 million people died in 2018 from TB. Worldwide, it's one of the top 10 causes of death. And we know that many people become ill with TB, but many people also, when treated properly, are survivors or go on to live a normal life. When we talk about TB transmission, it's person to person, but it's through the airborne route. Somebody has to breathe in TB bacilli or TB bacteria deep into the lungs, and then it'll infect the deep lung and either be encapsulated by microphage, or it'll grow into a lesion, and then you'll have active TB disease. And then yes, once you get the infection in the lungs, it can also disseminate to other parts of the body. But generally, when we talk about TB, the major route is airborne through small particles or droplet nuclei or microdroplets. TB is not spread by shaking someone's hand, touching surfaces, sharing a drink, or any of these other contact transmitted modes. When we talk about COVID-19, there's just a little bit of confusion here. On the 11th of February of this year, WHO announced the official name COVID-19, which is not the name of the virus, it's the name of the disease. So it basically, CO is corona, VI virus, D disease, and 19 is the year which they theorized it jumped from animals to humans. And this slide I took off the WHO website last night, and there are almost 2.5 confirmed cases globally, and almost 170,000 deaths globally due to the coronavirus, to this particular one. And when I say this particular one, the actual coronavirus is called coronavirus 2, and some people abbreviate it as SARS-2. It's a novel or new coronavirus, though we know coronaviruses have been around for a long, long time. Some of the most recent coronaviruses are SARS and MERS, and I know most of you have heard about them. Person-to-person spread of coronavirus is slightly different than TB. We know the coronavirus, similar to flu, is spread mainly by contact. You'll see that I have a question mark after the 6 feet 2 meters rule, because there's more and more evidence that 6 feet or 2 meters separation alone is not sufficient. We know that people will generate respiratory droplets, and respiratory droplets can be from very small to very large by coughing, singing, sneezing. If you're homeschooling, it could be shouting. But these droplets can land in the upper respiratory tract and infect the person. And there's thought too that it can be inhaled deeper into the lungs. And we suspect that, you know, people who are not showing symptoms have infected other people. So how easily does the coronavirus spread? Well, we know that it spreads very easily and sustainably between people. Information from the ongoing pandemic suggests that it actually is spreading more efficiently than the common seasonal influenza, but not quite as efficiently as measles, which is highly contagious. So what do we need? We need to think about, you know, cleaning of surfaces and air. And when we talk about cleaning of surfaces and air, we generally talk about environmental controls, but cleaning the air, one thing we're going to be talking about today is respiratory protection, because in essence, it's cleaning the microenvironment or the area around the person wearing the mask or respirator. We'll talk more specifics about those two items. So let's talk about the hierarchy of airborne infection prevention and control. I'm going to show you a hierarchy that you may or may not have seen before, but it's an analogy that I like to use when talking about infection prevention and control. On the left, we have the traditional hierarchy. We'll have our managerial and administrative controls, which are your policies and practices. We'll have our environmental controls, which are your ventilation, your germicidal ultraviolet, your room air cleaners, and other items. And then the third tier is personal protective equipment. And again, we'll talk specifically about that in detail. But on the other side, I have three categories. I have the worker, the patient, and the facility. And the reason I have that is we might have different, or we will have different managerial and administrative controls for the worker to protect the worker. We may have different managerial and administrative controls to protect the patient and to protect others from the patient. And the same thing goes for environmental controls and personal protective equipment. So managerial controls and administrative controls may be the same, they may be different depending on the category. So when we talk about managerial and administrative controls, one key to that is really training. So what I want to do is just show a brief video of cough etiquette and respiratory hygiene. And this is from the Public Health Agency of Canada.
The Public Health Agency of Canada proudly presents coughing, sneezing, and you. Every time a person coughs or sneezes, millions of disease-causing germs are launched into the air.
Yuck.
Polite people cover their mouths, but using your hands can spread germs to other people. Until recently, the best advice was to use the inside of your elbow. Germs get trapped in the fabric and die. But we now know that even these precautionary measures aren't always sufficient to prevent contamination. That's why your best bet is to sneeze into the back of your knee. Here, people are far less likely to come into contact with your germs. Can't reach? Then use the back of someone else's knee. They'll be glad you did.
Woohoo!
By following these simple steps, we can all help make the world a healthier place to live. This has been a presentation of the Public Health Agency of Canada.
Now, obviously, that's not true. But when we think about cough etiquette and respiratory hygiene, quite often we look at a poster like this. This doesn't say TB, it doesn't say COVID-19, it doesn't say influenza. It's really good public health. So when we take a look at this poster, there are really three types of controls here. One is, coughing or sneezing into a tissue. The other is into the upper sleeve or your elbow. And the third is using a surgical or procedure mask. But if we take a look, what's often missed is the very bottom here, where it talks about cleaning your hands after coughing or sneezing, washing with water and soap, or some other kind of alcohol-based hand cleaner. So when we're talking about cough etiquette, we have to absolutely, positively include proper hygiene. So let's go back to this, and we take a look at WHO's recommendations for use of a mask. And what they say here is extremely important. It says if you wear a mask, then you must know how to use it and dispose of it properly. Quite often, patients are just given a mask. Some staff members are just given a mask, but without the knowledge and education on how to properly use it and dispose of it, you're potentially putting somebody at risk, and that somebody could be you, it could be another patient, or it could be the person to whom you gave that mask. So let's talk about why instructions are important. What I'm going to show you is a video that a friend from Latin America gave me, and it was during a flu epidemic. There's no audio to this, so I'll narrate it, in which they were taking a look at, how were people responding to this epidemic. And there's a news reporter here who is talking to somebody about surgical masks and what do you do. So this guy has one, and now he's going to interview somebody from the general public. And the thing that I found impressive in the beginning was, this guy actually knew about masks. And when you take a look, when asked, okay, do you have one? How do you wear it? He tries to give instructions, and look, he's got one in his briefcase. So he pulls it out, and now he's going to show the news guy how to put it on. And what do you think? Do you think he was instructed on how to wear it properly? But then the news guy has to correct him. I mean, this guy even fixed the nose piece, which really wasn't a nose piece. But without proper instructions, I haven't really seen anybody other than this video put it on 90 degrees off. But we want to make sure that people understand how to wear them properly, when to wear them, and what are the benefits and risks of wearing something like that. Let's talk about coughing or sneezing into your elbow. Is that a good thing? Well, next time you have some candles lit, or you can just put your hand underneath your elbow, but just blow air into your elbow or cough or sneeze and see, do you feel the air coming around your elbow? And I think you'll find yes. So the elbow doesn't necessarily catch 100%, depending on how accurate and how close you are to the elbow, it may be more effective or less effective. But now you have contaminated your skin if you don't have a long sleeve shirt. You've contaminated the shirt. So you have to make sure you're not touching that spot, getting it on your other hand, and transmitting it around. So the issue with coughing or sneezing in the elbow is it does not necessarily capture that much of the airborne fraction of what you cough or sneeze. So what I usually talk about when I see a poster like this is, is that really a good method? It's better than nothing, but it may not be as great as some people think it is. And how about disposal? What do you do? You're not going to throw your shirt away. You'll hopefully wash it. But for your tissues and your respirators, we want to dispose of it properly. And what do we see nowadays? We see masks, we see gloves, we see PPE just scattered everywhere. And I was just at the grocery store the other day, and we saw them in the parking lot. So we need to make sure people understand the proper disposal. So let's go back to this hierarchy. We talked about the managerial and administrative controls. And related to personal protective equipment, we need the policies in place to make sure that the workers and the patients use PPE appropriately, that they have the appropriate PPE. What we're going to focus on for the rest of this talk is really the specifics of personal protective equipment. This is a CDC graphic in which they talk about the preferred PPE use and acceptable alternative PPE. The only difference between these two is the left one has an N95 or greater respirator, and the right one has a face mask. They all have gloves, gowns, face shield or goggles. And again, the only difference is a mask versus a respirator. Which brings me to the next topic. We have to be careful when we're talking about masks and respirators. There's no such thing as an N95 mask. There's an N95 respirator. When we talk about masks, we're generally talking about procedure or surgical masks. A respirator actually is a legal term, that it's something that meets certain requirements, and we'll go into those requirements after we talk about masks. So when we talk about surgical or procedure masks, why do they call them surgical masks? Well, they're used a lot in surgery. Why are they used in surgery? They're used for two purposes. One is so that the staff working in a sterile field, if they cough and breathe, whatever particles they're exhaling are caught on the inside of the mask. The second reason they use it is as a shield. So if there's a splatter, it'll be on the outside of the mask and not into the person's mucous membranes, nose or mouth. Though the deficiency in this photo is nobody is wearing eye protection, which they should be. Here's an architect from Peru. Why is she wearing a surgical mask? It's not really to protect her from breathing in TB or coronavirus. It's really so that when she's walking around, if she is infected with coronavirus and not showing symptoms, then she's not spewing out organisms. If she has the flu and is coughing, she's not spewing out as many organisms to the environment. And both in a study that was done in South Africa with patients and with the laboratory study with the University of Cincinnati, we found that surgical masks are in the neighborhood of 50% effective at reducing the number of small particles emitted from somebody coughing. So they are great for protecting the environment. Here's a TB patient. Why is he wearing a surgical mask? Well, the reason is simple. They have a policy in this hospital that before visitors come in or staff member comes in, that patient has to put on a surgical mask so when he or she is coughing, that whatever that person is coughing is at least partially collected in that mask. Large droplets will be collected at much higher efficiency than very small droplets. Here I am standing in front of a grocery store here in Florida with my homemade mask that a classmate from high school made for me. in which, you know, I'm wearing it not necessarily to protect me from somebody who might have coronavirus as much as protecting others from me, not because I know I'm infected, but I could be infected without having symptoms. But also helps me that if somebody's coughing directly in front of me, I may not filter out the very small particles, but at least the droplets will not be inhaled. Here's a neat graphic that somebody had sent me of a mask that was made out of denim. It'd be pretty hard to breathe through, but the advantage of something like this is if you get thirsty, you can still drink while you're wearing a mask. Now, obviously that's not approved, but there are many, many designs for masks. There's not one perfect design, just like there's not one perfect respirator. You need something that's comfortable, that fits not necessarily super, super tight, but relatively tight, and that has, you know, some minimal level of filtration, and also something that's cleanable, that you can take and just perhaps throw in the washer and wash after you. Again, they come in different shapes, different styles. You can see videos. This woman is actually doing a video showing different ways of making ties for the mask. Now, I'm a dog person, and here's a puppy asking, "Mom, why are humans wearing muzzles?" And the wise mother says, "Honey, they're too dumb to learn to sit and stay." And in reality, it doesn't matter if we're talking about TB or influenza or coronavirus. It's really the same thing. You know, we want people to understand how to protect themselves and how to protect others. So we need to be able to follow instructions, but we need instructions to follow. Let's take a look at this graphic. This is somebody coughing. And what do you see? You see lots of particles coming out. This is a modern picture with thermography as opposed to just high-speed photography, but it looks very similar to the 1942 photograph. If you're wearing a mask, then instead of these particles going way out into the room, they're collected for the most part within that mask. So let's talk about selected PPE, and we're going to sort of summarize masks and respirators, and we'll go into details about respirators. But I wanted to put this slide in the middle just to make sure that we understand the difference between the two. When we talk about masks, we're talking about protecting or dealing with large droplets. We can protect the environment from the wearer. So people, whether it be a patient, healthcare worker in the case of surgery, we can protect other people from the wearer of that mask. We can protect surfaces, because if we capture a lot of those particles on the inside of that mask, then there'll be fewer droplets or particles on the surfaces. And to a certain extent, for large droplets, we can protect the wearer from the environment. So if there are large droplets in the environment or you're near a coughing patient, you know, a lot of those particles will be captured on the outside of the mask. Now, if you touch the outside, then rub your eyes, well, then you're just transferring the virus from the outside of the mask to your eyes. Remember before we talked about microdroplets and droplet nuclei? Well, respirators are great for that. They can be used to protect the environment from the wearer if there's no valve. You know, respirators have valves. So if you're wearing a valved respirator and cough, what you're coughing comes out through that valve, so you're not protecting the environment. But if you have a valveless respirator, so if you're in surgery with an infectious patient and you want to protect both the wearer from the patient for small particles or microdroplets, droplet nuclei, and you want to protect the patient from what you might be exhaling, then a respirator with no valve would be appropriate. And of course, respirators are really designed to protect the wearer from the environment. Yes, they can protect the wearer from large droplets, but unlike masks, they can also protect the wearer from the very small micro droplets or droplet nuclei. So let's talk about respirators for a minute. A respirator works by putting something in your face, breathing in, creating negative pressure, then that air comes in through a filter and then into your breathing zone, your upper respiratory tract and lower respiratory tract. There are 3 different kinds of filtering respirators in this photograph. The left one is called a filtering facepiece respirator. So really it's just a filter that sits on your face. The standard N95 is a filtering facepiece respirator. The one in the middle is a half facepiece elastomeric or rubber respirator with filters, or these round cartridges that have filters in them. And then the one on the right is a full face, so it protects your eyes as well, respirator. When we talk about N95s, we want to make sure that we understand what N95 stands for. It's a US standard by CDC and NIOSH. The N means it's not resistant to oil. So most healthcare settings are not industrial settings, so you will not be exposed to oil. And the filter is 95% efficient. Not 100%, but 95% efficient. So when we talk about N95 respirators, they're perfectly fine for most coronavirus and TB situations. But if you're doing an aerosol producing or aerosol generating procedure, you might consider a higher level of respiratory protection. There are also European standards. Now, the European standard tests their respirators against both oil and non-oil aerosols, and also take a look at what's called total inward leakage, which is the total leakage of the respirator, which could be through the filter, through the valve, and through the interface of the face and the respirator itself. We're going to only talk about P2 respirators. So the filter on a P2 respirator is allows 6% penetration or 94% efficiency, which is pretty close to 95 for the N95. But it also is tested against oils, so it allows less than 2% leakage or 98% efficiency. In addition, and this is not included in the US standard yet, but for the total inward leakage, a P2 respirator means that the wearer is assured with proper fit testing of no more than 11% leakage or 89% clearance or cleanliness of air. Now, when we talk about US certified respirators, we'll be talking about the N95. The FF here means filtering facepiece, so it's a specific type of respirator, and the P2 is that level of filtration. So an FFP2 or higher respirator by European standards, again, is very acceptable for coronavirus and most TB situations. But again, when dealing with an aerosol producing or aerosol generating procedure, you might need a higher level of protection. So let's talk about real versus counterfeit respirators, because I get this question a lot. Here's a respirator. Is it real or is it counterfeit? Meaning it doesn't really meet any of the standards. Well, I'll go into a little more detail on how I determined this, but this one is not. It looks like a respirator, but it's not. And we know it for a couple reasons. One is, if you see the cursor here, the name was printed after the respirator was manufactured. It wasn't printed on the flat fabric. And it doesn't say what the approval number is on the respirator. How about this one? Is this real or counterfeit? Well, there's only one strap. So that's not common for a respirator. How about the fit around the nose? That's not very good. How about it folding in half? And that's mainly because of the pressure point from one strap. And there's really not much in the way of filter. There's just a little piece of gauze. Here are two folks wearing respirators. Let's take a close-up. And here it says, it gives the manufacturer, the make and model. It tells you this is the European standard and the approval number. So this has the minimum required information. If it does not have the minimum required information, it's not a true European or US respirator. If it has the information, it may or may not be. It may be a good counterfeit, but if it does not have the information, it is not. Here's a translator I used one training course, and this is the same guy that was wearing the respirator earlier. But let's take a look at her respirator. Here again, you can see that the stamping or the labeling was done after the manufacturing of the respirator. So that's definitely not a real N95 respirator, nor does it have the approval number. Now this one, you can see the ripples, but the labeling was done when the fabric was flat, and it has the approval number here. So you'll see this on the website. Here's a link to a CC NIOSH page for N95 respirators. Unfortunately, there's not a similar page for European respirators. But if we take a look here, this is the imprint from that one respirator. But here's the company, High-Tech. The respirator model is SH9550, yeah. And it has the TC or the approval number, 84A3713. And it has instructions for the respirator. So this is one way to look up a manufacturer and see, okay, is it at least gone through the approval process? And we have to make sure we follow user instructions. Every respirator will talk about how to put it on, how to take it off, when to wear it, how to adjust it. But there are other classes of respirators. There's something called a powered air purifying respirator. That respirator has a battery powered fan. It pulls air through a filter and pushes it into a facepiece or a hood. So you're getting clean air into the breathing zone of the worker. These are advantageous because they're not tight fitting. It's easier to communicate. You may have a perception of it being cooler, but you're relying on that battery. And if the battery stops, then you have zero protection. But some facilities are using something like this for high-risk procedures. An atmosphere or air supplying respirator, that's really not necessary for TB or any of the other airborne infectious diseases, unless you're dealing with a bioterrorism agent. And we're not talking about that today. So when we talk about program elements, what do we need in the administrative control portion to ensure proper respirator program? And that's, we want to make sure people are trained. We talk about training. We want to make sure that people are medically evaluated. It's a very simple evaluation, but you don't want somebody with severe asthma to be having to wear a respirator. I'll only briefly mention fit testing, but fit testing is one way to ensure that a particular model or size actually fits and protects that worker. We want to make sure that we have quality respirators, or we're using the appropriate respirator in the appropriate time and place. We need to understand about maintenance, care of respirators, and also an evaluation. Are people actually wearing them properly? Are they wearing them appropriately? Are they wearing them when they're needed? Here's just a picture of a box that talks about, a couple boxes that talk about how to put them on. Qualitative fit testing is very effective. The result is very similar or equivalent to quantitative or more expensive fit testing, and it's relatively easy to do. I already talked about this, about face seal leakage, and your fit testing will help you understand, do you have face piece leakage. It may not tell you if it's through the filter or the valve or the interaction of the face, but at least tells you that yes, this respirator fits, or no, it doesn't. Let's take a look at this photograph for a moment. What's on the other side of this open door? In this case, the open side of that door is an MDR TB patient. So the first question is, should that door be open? Nah, no. What is he wearing to protect him from what might be airborne? What is she wearing? She's double protected, right? Because she's wearing a surgical mask and an N95 respirator. But how will that surgical mask affect the fit of that respirator? It will adversely affect the fit because that respirator is no longer sealed against the face. You have ripples of that surgical mask, so you can have a lot of leakage around the face. So how about this person? Is she ready to be in close proximity to a coughing TB or COVID-19 patient? Looks like she's just wearing a surgical mask. But in reality, what she's doing is she's wearing a surgical mask over top of an N95 respirator. So for a very small cost, what is she doing? She's protecting that respirator so that the respirator can be reused, but the surgical mask can be disposed of. And I'm not endorsing 3M, but 3M is one of the companies that sells different size models of respirator. This person is relatively small, and this is a regular size respirator, and that's why I put the actual number up top. It's an 1860 N95 respirator. But that looks kind of big on her. Now here is the 1860S, which is a small. So when we talk about respirators, one advantage of fit testing, it tells us, okay, is a person wearing the appropriate size of respirator? These folks are doing a bronchoscopic procedure, wearing surgical masks that are only tied at the top. Is that appropriate? They are not respirators. So if there's any aerosol produced, in this case, there's very little protection. How about this group? They're about to go into a laboratory. This is a training class. But if you take a look, this guy is protecting his neck. This guy is protecting his mouth, but not his nose. So when people are wearing respirators, we want to make sure that they're wearing them properly. So we have to help each other out. Here we are sitting, waiting to go into the hardware store the other day. And what do you see here? Here's a guy walking into the store. And here he is wearing a respirator on the back of his neck. I couldn't take a picture inside the store, but what do you think he was wearing inside the store? The respirator on the back of his neck. So we need to make sure people understand, how to wear them, where to wear them, where to store them. In this case, this person stored it in the desk drawer. I doubt they used it very much, but it got pretty crumpled. So we want to make sure we select the appropriate respirator. The one on the top left has a valve in it. And we talked about when you should not use a valved respirator. This is the third picture is the half face piece elastomeric respirator. Now we don't want to use this type of a filter because you cannot clean that filter. If you have a cartridge where the filter is inside of plastic, then you can wipe down both the face piece and the outside of the filters. So any fomites or droplets on the outside can be wiped clean. And then the bottom right is the hood for a powered air purifying respirator or PEPR. If we take a look at the user instructions, and again, I just picked one manufacturer, but it gives some information about you have to have a written program, so that's your administrative control. But it tells you when you need to change out the respirators. So until damage, breathing becomes difficult, or contaminated with blood or body fluids. So when we're dealing with something that's spread by contact, then we need to be more concerned about the outer surface of the respirator. If we're only concerned about TB, and nothing else, no co-infection, then we're less concerned about this. And just to let you know that, I'm not just talking, trying to tell other people what to do. Here in the US, we do have policies for respirator reuse. It does talk about mainly TB, but it also says that we can use it for other organisms, but we have to use caution because those other organisms may be spread by fomites or by contact. A very frequent question, I'm just about finished, deals with disinfection of N95 and FFP2 respirators. We know from many old studies and a few new studies that vaporized hydrogen peroxide can disinfect respirators and not damage the filters or filtration efficiency or the straps. We know from some studies also that the use of ultraviolet germicidal irradiation, or GUV, can be used to disinfect respirators, but that germicidal light can slowly damage the surface of the filters, and it definitely damages the strap. So there's a National Institute for Allergy and Infectious Diseases just released a study recently that talks about, well, if you use UVGI, you could probably only reuse your respirators twice because of the damage that it does. Dry heat up to 70 degrees is another option, but there is a caution about reuse because that high heat damages the straps. When we get to super high heat, yes, you can disinfect it, but you're going to be damaging the filter and the straps. Same goes for ethylene oxide, formalin or formaldehyde. I wouldn't want to breathe a respirator that's been disinfected with that. Same thing with bleach. It'd be hard to breathe through. Soap and water, the problem with that is you remove some of the filter efficiency because of the surfactant in the soap, and the same thing with alcohol. You're going to reduce some of the efficiency of the filter. So the conclusion here is you can use vaporized hydrogen peroxide, and with certain limitations, you can use the UVGI and dry heat. So what can you do? Be proactive. Ideally find well-designed respirators. When it talk about decontamination and cleaning and whatnot, well, it's not easy to decontaminate. Cleaning, not with the filtering facepiece respirators, but you can clean the outer surfaces of an elastomeric respirator. Keep your respirator clean, cover it with a mask when you're wearing it. And storage, it needs to be a clean, dry place, not in the plastic. And when in doubt about the respirator, then throw it out. So to kind of give a summary of respiratory protection, we need lots and lots of SOPs. Healthcare workers, ideally, a valveless certified respirator when in close proximity to patients. Why valveless? So they're not expelling potential organisms, especially if they're infected with coronavirus and asymptomatic or not symptomatic. You can also use it to protect yourself from microdroplets or droplet nuclei. And I just mentioned protecting others. The general public, we talk mainly about, protecting the environment. You can protect yourself from large droplets, but you're protecting others from you. So the second summary slide really is, what's our mission? Our mission is to work hard, play hard, promote good public health, be safe, and enjoy life. So I like to enjoy life. This is one of the last pictures I have of my father. But as I mentioned earlier, we're dog people. So here's a photo somebody sent me about their dog being ready to go outside. And the dog has its mask, its gloves, its toilet paper, and its hand sanitizer. So it's ready to go. So on that, I thank you very much for your time and attention. Again, I'm with the End TB Transmission Initiative, which is part of the Stop TB Partnership in Geneva. This group's funded through the U.S. Agency for International Development, or USAID. And if you go to this web link, you'll see there are 3 documents there you might find of interest. There's one on personal respiratory protection, one on fit testing, another on the use of germicidal UV. So I thank you very much.
Thank you
And
very much, Paul. Thank you so much. This is very informative, very informative presentation. So with that, we have a few questions. We'll start with a question for Ed. And the question is related to administrative control. So Ed, if you can kindly elaborate on the kind of key administrative controls for respiratory protection, barriers for institutionalization, of the administrative controls, and any other issues that related to administrative controls.
Thank you, Hala. Well, I think I need to break this down a little bit between tuberculosis and COVID, slightly different. For tuberculosis, we've sort of had well-established concepts around administrative controls, and largely in both cases it's source control, and that means identifying cases so that you can limit their infectiousness. With tuberculosis, the best way to limit infectiousness is to promptly treat those patients, and as some of you may know, we have developed some approaches to that, one of which is called FAST, Find Cases Actively, Separate, and Treat, which is really built on molecular diagnosis, including drug susceptibility testing, and rapid implementation of effective therapy. And a number of studies now have shown that that will reduce transmission. Most impressively, one in Russia that published, which showed a decrease in the generation of MDR-TB with the rapid diagnosis of drug-resistant tuberculosis and the rapid proper treatment of drug-resistant tuberculosis, as opposed to treating drug-resistant TB for a while as drug-susceptible TB, during which time they continued to transmit and generate other cases. So for TB, in particular, the most important administrative control is identification and treatment. Separation plays a role, obviously, in triage, and separation also plays a role, and that is also part of basically initially identifying people who may have tuberculosis and promptly diagnosing and treating. With COVID, there is some similarity in the sense that there's an enormous effort to identify cases early to avoid transmission. One of the difficulties with COVID compared to TB is that it appears to be infectious, or can be infectious, well before symptoms are evident. With tuberculosis, we use things like cough screening, asking about fever and other symptoms, and understand that most people who are asymptomatic are not very contagious. With COVID, that may not be the case. It's so early in this epidemic, believe it or not, that all these facts are not 100% clear, but there are evidence that you can carry COVID in the nasopharynx and be infectious. So but still testing. So, at least our news media is full of the need for much more testing than we've been able to do in order to identify cases early and do case finding to identify who they have been in contact with. Now, during the peak of the epidemic, case finding is usually not very possible. But as we get down to fewer numbers of cases and want to open up society again, one of the approaches that is being taken is administrative. It's identifying patients who have COVID early, lots of testing, and doing contact investigation, isolating those cases that are identified by contact investigation to slow the spread of the disease, since we have no effective treatment at the moment to interfere with transmission. I'll stop there.
Thank you very much, Ed, for this. Our next question to Dr. Gregory, and this question related to key barriers in using respiratory protection devices. And I think you have a few slides to present, Gregory?
Yes, I have some slides.
Okay.
Very few, actually. And if it comes to key barriers to use a personal respiratory protection, from my experience working in TB services, I believe the main reason is low compliance of staff. And the main reason for that is not quite understanding the risks of airborne transmission of this infection. But what I see now around during the pandemic of COVID-19, that people do understand the risk, and because of that compliance and interest for using of effective respirators or masks is actually very, very high. So understanding the risk and understanding the basics of airborne transmission of infection is a key factor of the compliance of healthcare workers and other people. So we have to educate, we have to make people understand the transmission basics, the TBIC hierarchy or COVID-19 transmission basics, and they will be very compliant if they do understand the risk. And the risk is very high in TB facilities without the TB infection control and without using of respirators. In Russia, previously the risk was relative risk of getting occupational TB was 22 or higher times higher than for the resident population. The next reason for low barrier of the use of the respirators is availability of effective respirators, and it's a huge problem all over the world, in Florida, in Russia, in China, and so on. So this is very, very important reason for not using respirators. So I think that we people who work in TB, who work in TB infection control, can lead actually the fight against COVID-19, to lead the preventive programs, because we do understand, next slide please, we do understand the airborne infection control principles, and we can teach, we can transmit our knowledge and skills to other healthcare workers, other healthcare facilities who face now very high risk of transmission of another deadly infection. So I just tell you a little bit about my personal and my colleagues' experience in this pandemic, and because we are actually the Center of Excellence for TB infection control, airborne infection control, we can provide guidance for our country, for healthcare people, for Ministry of Health, about the implementation of effective preventive measures against the airborne transmission of COVID-19. Like we here in Vladimir, we actually developed the prevention part of the official recommendations of Ministry of Health, and this is about the airborne prevention again. So we and everybody who participate in this webinar, not only faculty but also participants, should be proactive in this high emergency situation in conducting webinars, video conferences, spreading knowledge, skills about components of airborne infection control, and first of all, for sure, is about the personal respiratory protection. We do in Vladimir consult other healthcare facilities about designing safe flows of patients, materials, safe collection of samples, about triage of patients, implementation of rapid testing, separation, appropriate airborne isolation, which is not just physical isolation, about environmental controls, basics on ventilation, UVGI, and again, respiratory protection equipment use. We also try to help them to establish their own personal respiratory protection program, which is very new for them. It's actually very difficult to build sustainable and sound program in these emergency times. But we can help them to implement the very basic, very important components of the program. We should help them to organize sound procedures for procurement of respirators, or certified respirators. It's probably impossible now to organize a fit testing for all healthcare workers in this situation, but for future we have to plan to educate and to implement this for all healthcare workers, not just for infectious disease or TB control services. Now here in Vladimir, I have my colleague just came from Moscow, and he brought first 100 cartridges for GenExpert to test for COVID-19. We will start validation of this test tomorrow morning in Vladimir, and so this is our input, and this is actually the component of the FAST strategy. So rapid active testing using the rapid methods and separation accordingly, isolation for those who need it, and initiation of treatment. It's again the input of the TBIC people into the fight against COVID-19. Next slide, please. A few pictures on the next slide show the panic on various levels during these times. I believe you can see around a lot of strange things like washing, disinfection of squares and streets in Moscow, and using gas masks, and this kind of use of respirators by high authorities without understanding the principles of donning, of the principles of use of the respiration. So again, our input is extremely important in this time. Next time, please. And next slide. What should be done, I believe, the previous one. What should be done, I believe, is to help to prepare for next pandemic. I believe this is not the last one, of airborne infection. And we have to build capacities of healthcare systems in terms of effective prevention of such infections. Airborne infection control program in Vladimir consists of several components. I just couple words will tell you. And administrative controls should cover all the procedures, stuff, manipulations related to any kind of risk. We should implement environmental controls, and there are only two main parts of environmental controls: is ventilation, mechanical or natural, and upper room UVGI. And they should be applied in medium and high risk settings. And personal respiratory protection is for high risk settings, really high risk settings only. Without good administrative controls, which can allow us to localize, to designate, to mark the high risk zones, we can effectively start using respirators. So because of implementation of such interventions, in my part of region of Russia, we have much less TB beds, downsized, but much more efficient services for TB care. We have very low transmission of TB, including drug-resistant TB, and we have very, very low or minimized occupational TB. Next slide, please. And when we compare the occupational TB risk in the TB services, TB control services, and other facilities, we realized that actually the transmission risk can be much higher in other hospitals. And I believe the airborne infection control are very effective, and we've showed that in few years we were able to actually reduce the risk to zero in TB control facilities in my region. Next slide, please. And again, risk of airborne transmission occurs, and it's about TB and or other airborne pathogens, like you see here that the risk in emergency hospital for TB now for COVID is much higher in other facilities than in the facilities which implemented airborne infection control. Next slide, please. And again, we have to understand the principles of respiratory protection. We have to correctly choose models, size, types of respirators, told about that a lot. And I will show you a small example. Next slide, please. Such simple procedure as fit testing, which takes only 10 minutes, can help us identify effective or ineffective or fake respirators. These two pictures are almost similar respirator, but on the right one is real respirators. A respirator complied with the EN 149 standard, and the left one is fake respirators with fake specific certificate, and the only difference is material, but you cannot say that it's without testing the respirator. Next slide. And you see that the strips attach different way in these respirators. And so we last couple of months we procured several thousand of such respirators, and they formally complied with the specification. But when we did the fit testing with our staff, we realized that only 20% or less of staff members pass the fit testing. So we started investigation, provided the certification testing, and found that the standard was not followed. So without fit testing, without such easy 10 minutes procedure, you cannot do it. You cannot have effective program for respiratory protection. Next slide, please. And again, I would like to refer you to the materials developed by ATTI. They provided on the website, just shown by Paul. And this about respiratory fit testing, just very brief, very precise information, easy to understand about different components of airborne infection control. Next slide, please. On different languages: Chinese, Russian, Spanish, French, Russian, English, for sure. And this is a website. You can find this information. Thank you.
Thank you very much, and this is really very comprehensive response to this question, and we'll make sure that we have these slides and information also available to the audience. Thank you again, Grigory. So I think Mary, she apologized. She has another commitment. So we can move to the other question. Then I think I would ask Paul to take her question after Carrie maybe respond to the next question, which is how can we change provider behavior so that they take respiratory protection seriously all the time? Thank you, Carrie.
Thank you, Hala. And thank you to Paul, Ed, and Grigory for their presentations and answers to questions already. And thank you to all the participants for staying with us. I think that Grigory answered this question very well moments ago, but I find that it comes down to education for healthcare workers to understand what the risks actually are and the perceived risk. If they perceive the risk to be low, then they are less likely to take respiratory protection seriously. It is very difficult to wear a respirator for many hours at a time, especially in warm climates. It is uncomfortable. It is, after a while, can get hard to breathe. So it is a hard thing to get people to want to do. So once they understand perceived risk, and as Grigory rightly stated, that when we have a global pandemic, whether it's COVID-19 or H1N1 a few years ago, the perceived risk becomes much greater, and so you have better compliance. But when we're just talking about maybe TB in a general hospital setting, people think their risk is low, so they're not compliant with or less compliant with respiratory protection. Education, we find in many parts of the world doing training with nurses and other groups of healthcare workers that there's a misperception about how TB is transmitted. And so we find that there's much more emphasis on disinfection of surfaces rather than the idea of preventing airborne or protecting against airborne transmission. And the other thing that Grigori also rightly mentioned is that we also find in many parts of the world that access to respirators especially is limited. And this is every day for going back years for TB care and people working in TB, that we have very little access to N95 respirators or FFP2s because of a low perceived risk of transmission. This is even in TB hospitals, and I know nurses and directors of nursing in some countries have had to fight with the directors of the hospital to purchase respirators for the healthcare staff. And it's taken 3 years of constant nagging, for lack of a better word, to finally get the hospital directors to agree to purchase N95s. So we can't wear something that we don't have. So again, education, perceived risk, but access is very important. And this pandemic has highlighted the issue of access to N95 respirators, but it will not end with COVID-19. And we need to be thinking every day, as Grigori also rightly said, that we need to be thinking every day about airborne protection, which kind of gets, and generally outside of a pandemic, it gets sidestepped for the hand washing and other things, or environmental protections, which are all very important, but the airborne seems to be perceived as a less risk in general. So it's nice, not nice to have a pandemic, but it does bring the extra attention to the airborne transmission. And so that hopefully we can keep the momentum from this, as Grigori also said, so that we are always thinking about airborne transmission, because there will be new diseases that we don't know about yet that will come up, and this will be helpful for that. Thank you.
Thank you very much. Thank you very much, Carrie, for this. This is really helpful. Now we have a question to Savim. And Savim, before we start, I think I should give the brief about Savim, because I had just a brief bio when we started. So Savim, Dr. Savim Ahmedov is a public health practitioner with more than 20 years of programmatic and patient management in the field of TB and HIV. Currently, he serves as TB, HIV prevention and M&E team lead with USAID Global Health TB Division. In addition to these technical areas at a global level, he is providing backstopping support to USAID missions in a number of countries in Central Asia and Africa. Prior to USAID, he served as director of the Field and Epidemiological Services section of TB program at Florida Department of Health, with main responsibilities for statewide program planning, implementation, monitoring and evaluation of TB prevention and control, as well as provision of technical support to implementation of TB control activities across the state's 67 counties. Thank you very much, Savim. And the question that we have for you related to what can donors, since you support programs from the donor side, what can donors do to improve respiratory protection in healthcare settings? Thank you.
Thank you very much, Hala, and thank you very much to all the excellent presentations and the panelists and the great questions. And thank you everyone who joined this webinar today. I will be very brief. Hopefully we will have some time to address some of the very critical questions that I also see coming through the chat forum. So I would like to make three very quick specific points. First, let me just say that through the American people's generosity and the US government's action, the US continues to demonstrate the global leadership in the face of the COVID-19 pandemic. Up to date, through the State Department and USAID, we have pledged more than $500 million in health and humanitarian assistance to help countries across the globe to respond to COVID-19. So in terms of that support to countries in responding to this unprecedented public health situation that we're facing, the U.S. is delivering the so-called safer, SAFER, and more secure world from COVID-19. And the SAFER is an acronym for the 5 main elements of our approach to supporting countries with COVID-19. One is really building upon the strong traditions that USAID has in supporting countries in scaling up community approaches to slowing the spread of COVID-19. As the previous presenters clearly showed, this is really absolutely a critical area in addition to healthcare facilities where the spread is currently ongoing. The second piece to that is to address the critical needs of the healthcare facilities. And those includes both the public, the private, including the faith-based facilities, as well as different healthcare facilities that we have, and also looking at the frontline healthcare workers and as well as patients. The third is finding, investigating and responding to COVID-19 through expanded disease surveillance and detection. The fourth piece of our strategy is to employ strategies to address second-order impacts, such as economic, social, governance, security, and stabilization. And finally, the fifth piece of our strategy is looking forward to the immediate future is for us to start readying plans for deployment of therapeutics and vaccines, which we all hope will come soon. Specifically to quantify my response to your question, as of April 17, USAID had obligated nearly $100 million to support infection prevention and control interventions. And those include cleaning and disinfection protocols, educating staff on personal protective equipment use, establishing isolation areas, and implementing triage mechanisms. The provision of PPEs, the COVID-19 case management and water, sanitation and hygiene support, as well as capacity building and training. This assistance, as I mentioned, builds upon decades of bilateral US support to strengthen public health capacity around the world and helping equip countries to respond to this outbreak and future outbreaks. And my final comment is in terms of the resources that the US government has pledged in response to COVID-19, just briefly to touch upon how that response is distributed to countries. So USAID is working very closely with departments of defense, the US Centers for Disease Control and Prevention, CDC, as well as other interagency partners to prioritize these countries that are receiving funding for the COVID-19 response. And this prioritization process is based on a series of factors such as caseloads and existence of community transmission, data indicating connectivity to COVID-19 hotspots, unstable political situations or displaced populations, as well as factors looking at the public health system stability, and assessment that the United States government support can make an impact on containing or mitigating the COVID-19 in the countries. So once USAID prioritizes the country for available funding, the agency works with various stakeholders, such as our US sister agencies and programs, to select the most appropriate mechanisms to fill the identified response gaps. And of course, USAID is also collaborating with national governments, multilateral organizations, non-governmental organizations, the private sector, and other actors working on the ground to support this COVID-19 response. Thank you.
Thank you very much, Savim. Thanks so much. And thanks to USAID, all the support to the countries to support COVID-19, as well as support other programs to ensure continuity of essential services, including TB, which is very, very important. So thanks again for the response. I think we have only a few minutes, and I know Ed and others, they have other commitments as well. We have many questions here. We may take only 2 questions, and then we will make sure that we have responses to other questions with the resources available to the audience. One of the questions I see here, what are chances of recovery if you diagnosed with COVID-19 and you have active TB? Maybe it's not very much relevant to this topic, but I think this is to the...
Hala, I can comment on that if you'd like.
Please, thank you.
I've only seen one paper from Wuhan, China, which suggests worse outcomes with both tuberculosis and COVID, either prior disease or current active TB. And I think, although this is speculation, that the reason is that any chronic inflammatory condition, whether it's COPD, asthma, coronary artery disease, and also tuberculosis, all predisposed to more dangerous immune responses to COVID. So outcomes tend to be worse with tuberculosis. So that would suggest a higher mortality rate.
Thank you very much. I think maybe we take another question. Isn't it much safer if we treat COVID-19 with airborne precautions?
Yeah, I think that's an excellent question, and I think the answer is probably, and it depends. And the reason I say that is we know that the vast majority is spread by contact. So until we have good control over contact, I wouldn't want people to be distracted by worrying about respiratory protection. So I think there's even a hierarchy here that we really need to have control over the physical distancing, the good public health, good public hygiene, and then deal with the airborne issue.
Okay, thank you very much, Paul. I think we are exactly on time, and thank you everyone. We have over 252 participants joined this panel since the start of the joined this webinar since the start. So thank you everyone, and we look forward to another webinar, and we are preparing for many other webinars, one on GUV and contact tracing, as well as many other topics related to infection prevention and control. So thanks again, Ed, Grigory, Carrie, Savim, Paul, thank you very much, and thanks everyone, and have a great day.
And thank you.
Thank you.
Thank you.
Thank you all.
Thank you all.
Can I continue to answer questions or not?
Please, sorry, I disrupted you.
No. On the Q&A thing, are you going to end this webinar?
Sure. No, I thought you want to leave by 9:30, but
Yeah,
yes,
I
please
actually,
go
it
ahead.
turned out
Yeah,
I'm an hour.
it's the note from you. Yes, sorry. Yes, please
So
go ahead.
I'm just answering some of these questions if you could. If not,
Please,
then we
please
can.
go ahead. I thought you wanted us to finish this by 9:30.
No. Thank you. I did say that, but it turns out I have to be there at 11, not at 10. So, do we want to do these vocally, or do we want to do them by writing?
We can do them by writing, since I see many of the participants already left. If it's okay
Okay,
with
well,
you.
then they won't see them anyway, probably, but anyway.
Exactly. Yeah.
Yeah. Okay.
Thank you so very much. And
Right.
Niraj sends his regards to everyone as well.
Okay.
Thank you very much. Bye.
All right, thank you so much, everybody. Gregory and Paul, we will be closing this down from our side. Thank you so much.
Okie dokie, we just finished the last Q&A, so perfect timing.
Great, thank you so much. Have a great
Okay,
rest of your day.
Bye.